You're tuned into the Advocai Health Podcast. We're here to talk about rare diseases, real people, and the ripple effects of change. Stories that move you, guests who challenge the norm, and vibes that keep it real. Hello everyone, thank you for tuning in for another episode of the ASH Podcast. My name is Omar, and joining me today is our co-host Ali. I'm sure you're all familiar with our voices by now, hopefully. For today's episode, we'll be kickstarting one of our special series in this podcast. It's called The Rare Tapes. The Rare Tapes is a series of episodes that allow us to take a deep dive into some scenario-based situations based on a topic of interest that we'll pick. And our job as co-hosts is to walk you through them and navigate a way to some kind of solution. These episodes will include a few sound effects in between to make your experience a bit more immersive. So highly recommend to have some headphones in, and also maybe don't listen to this while you're driving in case we put like sirens or something in the episode. Don't want to disturb you. So definitely have a comfortable space and listen to this.
That's a good point with the driving actually. But just to preface, like, this is the first time we're doing it, so if doesn't work out as well as we hope to, give us a chance. We're going to try again, and hopefully it'll be a fun series. But so the topic for today, we will be focusing on symptom and pain management. We'll be talking about what happens when pain, one of the most universal human experiences, becomes invisible, inconvenient, or ignored in healthcare. You'll hear 3 scenarios today, all real-world inspired, where people living with a rare or chronic condition encounter some form of disbelief or dismissal when they're at their most vulnerable. And so with that being said, let's dive into the first one.
All right. So scenario 1 is called the Calm 7. It's just after midnight. You've had this kind of pain before. A full body, deep muscle burn that feels like acid laced with electricity. But tonight it's more intense. You're wheeled into the ER, visibly struggling, but not screaming. You've trained yourself to breathe through it, to stay functional. You've lived with this rare inflammatory condition for years. You know the drill. The nurse walks over with a clipboard and asks, "What's your pain level, 0 to 10? You say, 7, evenly. Your voice barely trembles. They glance up. 7? They repeat. You seem pretty calm. They jot it down anyway, then walk away. Minutes later, the attending physician enters. He glances briefly at the monitor. Vitals are stable, he mutters. We'll try some Tylenol and see how you respond. You've already submitted an ER protocol to the hospital. You know what works for your body. Ketorolac, IV hydration, and muscle relaxants. But right now, none of that's even on the radar. And in that moment, you realize staying calm to survive your condition has made your pain less believable. All right, so that is the scenario. Now we'll have a little bit of a discussion. Ali, you want to start?
Yeah, sure. To be honest, that line, you seem pretty calm, it's something I think many of us have heard, and it completely ignores like the survival instinct people have to like stay composed, especially for those who may have lived with a chronic pain or an episodic pain for years, or even like for a small amount of time. I'd love to give an example of like maybe that I've had in the past, but I want to get your thoughts first.
Yeah, no, 100%. When I was reading that myself, I think you seem pretty calm. It's like kind of a triggering statement, especially for certain people who have like lived through those conditions, and they kind of experience the ups and downs. So I think from a physician's point of view, it's kind of like, this is kind of very different from what we see from different patients. They compare your situation to maybe the diverse set of patients that they've seen across their life, like, in their job. But for the patient themselves, they don't really think of that. They don't really see that the physician is looking at a different perspective. It's just that, when I'm in front of the physician, I want to hear some words that kind of make me feel a bit better. And it's really that communication that kind of sets the tone for their experience. And if it starts off in a way that's opens the door for miscommunication or misunderstanding, it just feels weird. So even like acting as the patient and me reciting that, it just I could understand, like, how the intensity was increasing as I was reading that. So that's definitely very interesting.
Yeah, 100% I agree. And like, it's so true though, because like if you think about it, every major scenario, every like disaster event, your first thing is like everyone tells you, okay, stay calm, don't panic, like think with a level head. And that goes for like pain situations too, right? If you're in pain, something bad has happened, nothing helps from panicking, or nothing
Yeah.
helps like over, just going crazy for something, when you should just breathe, think, and do the like what makes sense logically. And then that's something that's taken as, oh, okay, well, it probably isn't that serious. And going back to like where I was talking about, maybe an example from my life is, I mean, this. I had lower spinal like pain a couple of years ago.
Yeah.
And like it was only after like an MRI that I found out that I had like 3 slipped discs, which, side note, at like 21, bro, when does that happen to someone at 21 years old? That was like the wildest thing.
Yeah, that was a crazy time.
Like 20 is the new 50, bro. 20 is the new 50. But it was insane where like I was getting such weird reactions where obviously I was in pain excruciatingly. And then when I was telling my doctor, and they were like, okay, well, here's try some painkillers. I was like, I've been trying painkillers. I know what works. I need like muscle relaxers because I can't like stand. And then so I had to get like prescribed ones, and then those finished. I had to try to get more. That was another issue. And then I got consultations from a surgeon, a neurosurgeon, and a neurologist. And that's where like I got different sort of reactions. And it confused me even further and almost like diminished where I was feeling, because the neurosurgeon was like, okay, this is the issue. Your like disc is blocking your nerves. Simple fix. If you really want to, surgery, we go in, we shave the bone, fix it. But it's not a like complete fix. This could happen again, right? It's not a one-time fix. I was like, okay, well, I don't know if I want to have lower spinal surgery if it's not going to even work, and that's also a risk. I went to the neurologist, and they did a nerve pathing test, because at this time it was my right leg, the nerves that were getting pinched, my leg would go numb when I was sitting down. And I mean, that's bad enough when you're like on a bus going 40 minutes from home to university, which, I mean, you were on most of those rides.
Really hard.
Yeah. And then I'll be honest, the times when I was driving, that was when it was also scary, because I'd be driving and my foot was numb. So I'd be like, and I'd be in pain too. I'd be popping painkillers like they were candy. Which, that was a whole different issue. But it was in that examination of my nerves when the guy asked like, okay, how much pain are you in right now? I was like, not a lot, because I'm leaned back, I was standing, so I wasn't being pinched. He did try to get me to do it on a scale, sort of. I don't remember exactly what I said, but I remember feeling that because I didn't, exaggerate the pain, he also wasn't taking me seriously. It almost felt like, okay, if I had a question, I couldn't ask it because he already knew his assessment of what I was feeling. And it really does like diminish your perception of what you're going through, because all of a sudden I'm questioning myself where, okay, if the doctor is saying that you're okay or you'll be fine, or just go do some more physio and you'll be okay, then you're probably fine, right? So maybe it's just in my head that because I've been going through this for a couple of months now, or like 6 months now, or 8 months, maybe it's worse. I think it's worse than it actually is, especially when he said about like going to do more physio. Dude, I had done physio. I had been doing physio and it was not working. Eventually, through some more conversation, I finally got him to like understand that, okay, these are the types of treatments I've tried. Nothing has really worked aside from more or less just painkillers.
Yeah.
And then I got him to give me like some actual advice on how to move forward. But there was definitely that moment where I'm just wondering, okay, is it in my head, or am I just making this more than it is, or
Yeah.
what, right? Yeah.
Yeah, no. I remember vividly, like very, like your experience during fourth year and stuff with like the pain management and stuff of going to classes, especially in the evening. It was kind of tough, and we always used to talk about it. Even during class, there were like moments where like you couldn't even sit, so it was like you had to like get up or stretch. So I remember that. But honestly, like what you said about your experience relates a lot with like what we're seeing here, and I think it just comes to show that pain expression, it's really just like a spectrum. It's not something that has an exact like black or white answer. And it really depends on the patient, right? Like if you're on one end of the spectrum where like you really don't want to exaggerate your pain because you've had negative experiences in the past where if you did, maybe they overprescribed you medications. So you're just like, no, you know what? I have to be stronger this time. I kind of have to hide the pain so that way I get to the solution faster. And then there's the other end of the spectrum where you over exaggerate, but then it's like you're again, there may be issues with the physician actually trying to understand what type of pain you're going through. So it poses the question, right? Like at the end where we said that in that moment you realize staying calm has made your pain less believable. So it's really hard for the patient, and like obviously only being in a patient's shoes you can really understand that type of confusion. Like you had that experience, and I've had family members who had that experience, so it's hard to really fathom like how people need to communicate their pain. So I think it comes to show again that pain expression, it isn't a reliable measurement of pain intensity, and especially for people who have specific conditions like rare diseases, people of color, or anyone who's just been sort of gaslit in medical settings. You really need to have other indicators and probably more conversation. I know that this situation was in the ER, so it's kind of like a first point of contact. Like they're just asking for the pain level. I'm sure that beyond this scenario, there would have been more conversation about their pain management or their pain like intensity. But even just the first question and like that comment of saying like, "Oh, 7, you seem pretty calm," is like it sets the tone, and it's a problem. So maybe just figuring out for, I think, physicians, residents, how we can communicate things in a way that doesn't sort of turn them the wrong way or something. I don't know.
I agree 100%. Like that first comment it says a lot, and they don't realize how much that gives away to the patient almost.
Yeah.
So it really like affects the way the patient starts reevaluating themselves. And that's why like I think patient-led pain protocols and documented emergency care plans like matter so much, so that you're not constantly re-explaining everything to the same not the same doctor, but like different physicians, because like you said, it's so relative to the person. Because not only to the patient but yet to the doctor. The one person might think 7's okay, 7's not bad if they look like this. Some person might realize that okay, they're putting on a brave face. Someone else might think that 7's really high for something potentially so small, because it's also based on who's receiving that information. And 100%. I think that the first it's how should I say it? It's like the first impression, right? You're in an ER. Your first impression of your doctor shouldn't be that okay, they don't believe me. Should feel something trusting, because at the end of the day, this could be someone who's your life is in their hands.
100%.
You want to believe that they actually know
what's going on,
and that they know what you're going through.
Okay, so I think we had a decent discussion. We still have 2 more to go, so let's move on to the second scenario.
All right. So scenario 2, it's just anxiety. You're sitting in a small room. You've had months of unexplained symptoms: crushing fatigue, tightness in your chest, muscle tremors, nausea, blurry vision. Every appointment ends the same. Your labs are fine. Today, you're seeing a new doctor. You list your symptoms again. You show them your symptom journal. Your heart's beating fast, but not from anxiety. It's just what your body does now. The doctor leans back in their chair. They nod slowly. They say, I think what we're dealing with is stress. They offer a referral to a therapist, recommend breathing exercises, maybe even a mindfulness app. You want to scream. You want to say, no, this isn't panic. This isn't burnout. This isn't just in my head. But instead, you sit, numb, tired of fighting for your pain to be seen as real. As the appointment ends, you leave with no test ordered, no lab drawn, just a pamphlet about managing worry. And as you walk back to your car, your whole body is still shaking. All right, so that's the scenario. I think kind of an intense one, but we'll get into some discussion about it. Any thoughts from you, Omar? Just first thoughts.
Yeah, no, I immediately a very different experience from the first scenario. I think this is more of like frustration rather than just like, oh, no one's believing me. It's just like, and it's very, very interesting because like, not only do they say that one line of, I think we're dealing with stress, and that already is a trigger for them, but it's then just the referral to the therapist, the breathing exercises, and then the
pamphlet.
to end it all off, the pamphlet about managing worry. Like that would really just make me scream, honestly. Like, imagine walking out the door, you already been misunderstood, and then you're given a pamphlet to kind of seal the deal and be like, you know what, this is something you got to take.
Well, if there's Yelp reviews for doctors, that one's getting like
that one's getting a bad one,
That's getting a bad one.
But honestly, like, this is not that uncommon. Like, it's things that do happen, and it's just misdiagnosis or just miscommunication. I think referring to like a personal experience, mine's is a bit more, I guess, extreme in the sense, but it kind of goes in alignment with what's going on here about anxiety. When my mom had her stomach obstruction and I had to take her to the ER. So just some context, she had colorectal cancer. So after her surgeries and everything, she just had like these obstructions that would come in on and off. They've faded away now, but it's just there were some moments where they were more complicated. So this one was like quite recent, I think like 8 to 9 months back. She had her stomach obstruction, and as a family, we know the patient, we know our mom, so we know that this is a stomach obstruction, although we're not doctors or everything, but just based on experience and patterns. We took her to the ER, everything went there. The ER's wait was like, I think 29 to 30 hours sitting in the same section. It's crazy. It's crazy. But the crazier part was, after 6-7 hours of getting the doctor to, or like whoever was coming in to do like the first checks, she was naming her symptoms about like, oh, like, my stomach is feeling this way. I've been having a bit of nausea and stuff like that. And vividly, I remember like, I don't want to say anything bad because maybe it's a student who came in, probably a resident or something. She did the initial checks and she was like, so based on your chart, I know you've had like colorectal cancer in the past, but these symptoms you're showing based on just our labs and everything, you seem to be okay. It may just be that you're kind of stressing out about maybe it happening again. So then I was sitting there and I was like, can we get a bit more of an analysis or diagnosis on this? Because I don't think, based on what she was going through at home, it was way more intense. Right now it's calmed down because she's seeing other patients around her. So it's like, oh, she's like, I guess a bit more comfortable because she feels like she's in the hospital now. But that doesn't negate the fact that, oh, she's going through something right now. Maybe it is an obstruction. I'm not a doctor, but maybe check more. And the student's like, yeah, well, we'll do more tests. And then, as you know, the ER waits kept going and going. They got referrals to some attendings in a different section, specialty, ruled some stuff out. And then when we got the surgeon to come in and we put her in a room, the surgeon was super busy, but he sent his physician assistant, who is a surgical physician assistant, so she knows what she's doing. Went in the room, they did like an x-ray, a CT scan, all those things, did some more labs, and then she literally came in the room and she said, "Yeah, you have a stomach obstruction." So
Our time.
I was like, okay, that makes a lot of sense. But the crazy part is that those 10 hours ago, when we had that first initial comment,
Yeah.
no one came to us in between those 10 hours to kind of remove the misconception, right? That so me and my mom were sitting there and we were having complete doubts. That I was like doubting myself, like, oh, is she even going through something? If she was even doubting herself, like, am I even having a stomach obstruction? Is this just me? Am I panicking? Like, if it makes you feel stupid, honestly, that your symptoms are not like kind of given priority or value, or like your own opinion on your symptoms, because you are the patient. So that whole like 10 hours of doubting yourself and then having a PA come and be like, oh yeah, so your initial guess was actually right, you do have a stomach obstruction, but it will resolve over time, like overnight. So she just stayed admitted and had an IV drip because she couldn't eat anything because of the obstruction, and it resolved the next day. But point being, coming back to the scenario, it's really, really important to kind of continue the diagnosis. And if there's a misdiagnosis, I think there's two parts to play. One is like the patient, for sure. They should definitely advocate for themselves more and be like, no, I feel like something is more wrong. But the thing is that if they have anxiety or they're stressing out, there's that power imbalance. They may not want to question the attending or the physician, and also they just are in that moment. They're so stressed, so it's harder for them. It's more so the role of the physician or whoever's looking at you to kind of continue the conversation and do more management. Obviously, my mom in my scenario, she was definitely more vocal, but I guess in this scenario we see that it's just like the shock of not being understood that led to them just being like, what the heck? And then they're just getting the referrals and they just walk out and be like, what, I'm tired of fighting. And I'm sure in this scenario, this patient may have gone through this so many times. They're just tired of like kind of trying to say that, I'm actually going through pain and there's other stuff we need to look at. So yeah, those are kind of my initial thoughts, honestly. It's just like, it's such a common story, and like chronic pain, rare symptoms, they get defaulted to like mental health very often. Not because anxiety isn't real, but just because it's used as a shortcut for physicians.
Yeah, 100%. And I mean, one, I couldn't agree with you more. Two, going back a bit to your mom's case, like I remember when this happened, you sent me like a picture of the waiting time, like
Oh yeah,
the hospital. You're like, I remember the message. You said something like, dude, I've been here all night and look at this, and it's like 10 hours waiting time. I'm like, what the bro, what do you mean?
Yeah,
10 hour more and you've been there all night. And
I couldn't believe it. And the time wasn't going down, it was going up.
It's going up.
Imagine, like, like when you're in school and you're waiting for like recess or like school to finish and you're looking at the clock, but then you're like so tired, you have like this hallucination that the clock's going backwards. That's what was exactly happening in the ER. The time was going up, and it's just like, oh my god, I feel like we're gonna have to stay here for the weekend.
It was doctors just going home. They're like, we're done for the day. Time goes up with one less physician to look at patients or something. Which like that kind of brings us back to the whole Canada's healthcare
100%.
Great,
it's a whole episode,
but it's a bit underdeveloped as a system. But
yeah.
Speaking, let's not go too far back.
Yeah.
Speaking specifically on that case, like how do you take a patient with such a specific history where she's had this issue, she has had colorectal cancer, she's having pain, and go, it's potentially just psychosomatic? And I'm like, okay. But the patient history, and then for 10 hours you leave that person thinking it's psychosomatic. Like, thank God nothing happened, but that could have been worse. Like 10 hours, that's not a small amount of time. Even 1 hour is a lot when it comes to a person's healthcare, and in an ER situation 10 is ridiculous. Like, and I can't imagine like the relief that would have came to you guys when the like physician's assistant came in and they're just like, yeah, no, you're having obstructions.
Yeah,
thankfully it was something that would fix itself. But just so that you and your mom know that what she's feeling wasn't fake. I mean, that's insane.
Yeah.
And 100% what you said, like in rare diseases or cases of rare diseases, they can cause anxiety, but it's not like anxiety just doesn't mean that, okay, that's the that's the cause, that's the root cause, or that's all you need to diagnose.
Mm-hmm.
I think where it happens is, and I could be wrong about this. This is just like limited knowledge that I have. Maybe now that you're gonna be a doctor, you'll learn more about it. But a lot of times I've heard that they tell like med students or like interns or residents that, you know, it's usually the most obvious answer or something like that, where with the diagnosis of a patient is usually the most obvious answer. And I get that is also for a reason to not, you know, go out chasing rare finds or like
Your
rare
labs and stuff like that.
labs or stuff, or something that might just be pointless, or like not because potentially also because it's a waste of resources, but also just because it might waste the patient's time or just be unnecessary and they could be treated faster. I get all of those things, but that shouldn't be drilled into someone's brain so much that they stop thinking logically.
Logically,
Right?
and
Yeah,
authority,
so I think logically, a person who has had the history that your mom had, yes, it could be stress. Yes, it could be anxiety. But with that kind of patient history, it's also very likely that they could be obstructions. So just because it's the simplest answer is just to say, yeah, it's stress. You'll be fine in a little while. Just like, you know, I don't know, take some anti-anxiety pills or something. Like, that's not the smart way to do things.
yeah.
But 100%, I think, and based on my like things I've heard, that's definitely something, that's a piece of advice that like if you're giving med students, if you're giving interns, residents, etc., right, you need to explain to them like, look, this doesn't mean you just stop thinking or stop believing patients or when they're trying to tell you something, because 100% it can be frustrating. And like they specifically to the scenario that we did, or the scenario we explained, how many times do you think this patient has gone into a doctor explaining that their heart's beating, or you know, they're feeling palpitations, blurry vision, nausea, all of those things, and every single one of them are just like, you know, try this new app, it might be good, or breathe, just
mindfulness,
just breathe, bro, like deep breath in, deep breath out, or here's a pamphlet about managing.
The pamphlet was crazy.
Pamphlets wild, like managing worry, bro. Do you even know what my worries are? You haven't even asked. How about you just fix all of them first and then give me the pamphlet or something? But no, these type of things is insane to me. The language that they use.
No, 100%. And I think at the end of the day, when I look back at that experience, I give some leeway to students because I'm like, well, I'm gonna become a student, but like just the fact that, you know, mistakes happen, you know, diagnosis is not like always perfect. And I know that from a student's perspective, when they see a case or they see a patient's file, they're also immediately thinking about next steps and like what's going to be our management. So that's why they kind of maybe resort to the simplest solution or the simplest diagnosis. So I give some leeway there, but the only thing I don't really give leeway for is those 10 hours. Those 10 hours in between, if someone were to have just come in and be like, hey, so we had a student come by and tell you this, just letting you know that we're going to do more tests, or we're going to do, you know, maybe we're not 100% sure. The certainty that that person gave to us in the first interaction is what led to a whole room of just doubts and like suspicion about like what's going on. So at the end of the day, like you said, language matters. Like for this case, imagine if the doctor had said, you know what, I believe you, these symptoms are real and I want to help you figure out what's going on. Like even just not having certainty and what's going on, but just saying, you know what, I believe you, or validate it. Just validate those emotions. Even if the patient is kind of getting out of control, sometimes to de-escalate you have to validate. That's what we learn in like crisis responding, right? So like so you got to validate sometimes, and then with time and with more tests and stuff, you kind of figure out what's going on. That changes everything. So hopefully you know, we can see more of that from doctors. But so we're hitting the 30-minute mark, but I know this is our first episode, so we will go to the third scenario. But the next one, we'll try to wrap up a little more quickly. We'll go to the third scenario now, which is called the Tylenol trial. You're sitting at your kitchen table, holding your phone with one hand and your insurance denial letter in the other. You were finally prescribed a targeted medication for nerve pain, a treatment that could slow progression and preserve your mobility. But the person on the phone, an insurance case manager, tells you it won't be covered. They say, you haven't failed enough first-line treatments. You'll need to try Tylenol and naproxen first. Then we can consider authorizing the specialty drug. You explain that Tylenol doesn't even scratch the surface, that your pain isn't from inflammation, it's neurogenic, tied to your rare disease. But they repeat the same phrase. This is just standard protocol. We call it step therapy. You need to fail the basics before we approve escalation. You hang up and sit in silence. You're being asked to fail on purpose, to stay in pain, before being allowed access to a drug that could change your quality of life. All because your condition doesn't fit the default path. Okay, so that is the quick scenario. Thoughts, Ali?
Yeah, no. Honestly, this one like irks me. The whole fail first logic is the most ridiculous, dangerous, dehumanizing part of like the healthcare system, especially for people living with rare or progressive illnesses. I swear, ironically, this kind of does fit my example as well from before, like the
Yeah, I was thinking exactly that.
but similar thing where like they gave me I think naproxen actually as like a muscle relaxer for the issue, and it didn't get fixed. It was after that they were like, okay, we're gonna get an MRI. I was like, why didn't you just think of that first? Like, I'm telling you, I couldn't stand, and your first thought was, try a muscle relaxer. But yeah, it's the idea that you have to go through this like protocol or this process,
Exactly.
right? That doesn't fit everybody, and in the meantime, you're just causing the patient more pain. But you give me your thoughts on it.
No, 100%. And the fact that this situation was related to someone with a rare disease, it kind of fits what we said in the first episode when we were talking about ASH and we talked about our podcast with people. I remember specifically one of those podcasts where someone was like, I was trying to go to a family doctor to talk about my GBS, and they kind of didn't understand it. They said, first try these treatments, try that. We're not going to diagnose you with this until it's proven that everything else has failed, and then we do a more, I don't know, genetic test or something just to see that, oh yeah, you have a rare disease. So being forced to prove you're suffering again and again before action is taken is really, really frustrating, and it's harmful. And the aspect of insurance coverage in this scenario was also really interesting, because that's a reality. People just think that it's just about testing medications, but for some people there's a financial barrier, right? They can't afford the drug that is proven and that can actually make a difference. So they fight their case to get that covered, but because of these step protocols, we're just told that no, you got to go through the steps, you got to kind of fail that. And even though the insurance person didn't say that you have to fail on purpose, is giving that, right? It's giving that you have to fail on purpose in order to get access to that. And it just really sucks when you see that there's a drug out there that is working for people, that has good results, and it's just money that's a problem or some other socioeconomic barrier. And you're just like, you know what, I have to kind of go through this step and just forget about my pain, forget about my quality of life, let it suffer for a bit to kind of get better in the future. That's a very toxic mentality for given to patients. So it can cause irreversible progression, especially for certain rare diseases that are genetic or something. We've seen it in our ASH podcast. It's just bad.
Yeah, no, 100% agree. Like it's not the right mentality to go through. Okay, where in life do you hear that like, oh, your health needs to get worse before you can treat you? I was like, whoa, what do you mean? Like, I thought the whole point of treatment is so that my health doesn't get worse. Like, that's why I'm coming to you. That's why you're a doctor, bro. Help me. It's like, nah,
help me.
Start like on the verge. When you're like, on the verge of death, then we'll save you. Like,
yeah, it's not reliable and all. It's not good.
No, but that's 100%. But that's where like you need more voices out there. That's where like community patient advocacy groups, they make a difference, because they help patients navigate these sort of scenarios and push more systematic or systemic reform into the healthcare system. And honestly, that's something we need more everywhere. But I think I can only really speak for Canada, or mostly Canada, because I don't have much experience or any with like other healthcare systems. But our issue is our healthcare system is overcrowded, and we've had this discussion before. So I think that makes it harder for some people to like speak up for themselves, because everyone's in a hurry. There's always the idea that, oh, there's so many more patients. Maybe if my pain's not as serious, it may not be real. It may just be psychosomatic. I'm just taking away time for someone who may need it more. And that is, I'm not going to say that's a mentality, but that could be an unconscious thought that patients have, right? Especially when they get these type of reactions or these type of, first interactions from their doctors. So that's definitely where these communities and this like advocacy group can help try to change that mentality.
Yeah, no, 100%. Systemic reform is what we need to push. So let's see what the future holds. Hopefully more students and more schools can kind of push that mentality and target the neglected pain points that we have. So we're wrapping up now. Apologies if this went a little over. It's our first time doing this type of episode, but I think we didn't do too bad. Just 5 minutes over the usual 30-minute mark. So pretty good.
Yeah.
And we had personal experiences to share as well. We wanted to give you guys a glimpse that these scenarios are not just things we made, but also they kind of relate to what we've went through and possibly what you guys have went through. So our point being, pain is personal, but the systems built around pain, from emergency care to insurance plans, often treat it like it should look one way, sound one way, or rank the same on a 1 to 10 scale. And that's something that we need to work on.
Yeah, 100%. And today's stories or scenarios and like the personal stories that we gave were just a glimpse into what it means to have your pain disbelieved, and why advocacy is not just about access. It's about, having dignity, or making sure you have that respect.
I agree, 100%. Dignity being the key word there. So if this episode hit home, share it with a friend, a provider, or someone who needs a reminder that all pain is valid, even if it doesn't look dramatic. And just a side note for our episodes, this was one specific type of episode, the rare tapes. And we have the other special episodes like guest episodes talking about something on the news, and just talking about rare diseases and stuff. So you will see a variety of things on this podcast. If you have any recommendations, please feel free to email us on advocihealth@gmail.com, and we'll be happy to implement that in the future.
Yeah, and if you've got a story of your own, if you are someone who, that doesn't have to be about like a rare disease that you went through, if you have something that you're passionate about. If you've seen our guest episode, we talked about food security and how that affects health. So if you've got anything related to healthcare that you think is very important and you want us to talk about, or you want to come on the show and talk about yourself, please do get in touch with us. Hopefully you know where to find us. If not, check out our Instagram page, is @advocihealth. And that should also have our links to all of our other socials and everything else. But until next time, guys, thank you all for listening, and hope to see you soon again.